Bismillahirrahmanirrahim. Assalamu alaikum everyone. Welcome back to OBG with Sadia Idrees. In our previous lecture, we discussed VBAC in detail. Today, we are not going to revise the whole guideline again. Instead, it's time to brainstorm. I'll give you a clinical scenario with different options. Before looking at the answer, pause for a few seconds and choose your option. And most importantly, try to defend your answer. Because in exams, knowing facts is important, but knowing how to apply those facts is what actually gets you the marks. So think, discuss, defend, and then we'll reveal the answer. Let's start with the first question. Here's our first question. On 29-year-old with one previous lower segment cesarean section, ask about having her chance of successful planned VBAC. What is the average success rate? So is it 45 to 50%, 55 to 60%, 72 to 75%, 90 to 25%? So pause and choose your answer. It's 72 to 75%. That is option number C. This is one of those figures that I really want you to remember for the exam. According to RCOG guideline, women with one previous lower segment cesarean section who are otherwise suitable for VBAC should be counseled that the overall success rate of planned VBAC is approximately 72 to 75%. Now, here comes an important distinction. If she has had a previous vaginal birth, particularly a previous successful VBAC, her chance become much more better, around 85 to 90%. So don't confuse these two figures. Average planned VBAC success rate is 72 to 75%, and previous vaginal birth is around 85 to 90%. And remember, the individual probability of success is not the same for every woman. It is influenced by factors such as previous vaginal birth, the indication for a previous cesarean, maternal BMI, and whether labor starts spontaneously or requires induction. So your magic number for this as single best answer is 72 to 75%. If the examiner simply asks you the average success rate of planned VBAC after one previous LSCS, 72 to 75% should immediately come to your mind. Okay, now let's move to the question number 2. What is the single strongest predictor of successful VBAC? Question option A is BMI less than 30 kilogram per m square, maternal age less than 40, previous spontaneous labor, and previous successful VBAC. Think for a moment. The correct answer is previous successful VBACs. Now, this is a very important exam concept. Several factors can improve the likelihood of successful VBAC. A low BMI, maternal age less than 40, young maternal age, and spontaneous onset of labor are all favorable factors, but they're not the strongest factor. The strongest factor is a previous vaginal birth, particularly a previous successful VBAC. These women have approximately an 85 to 90% chance of successful vaginal birth. So if a single best answer gives you multiple favorable factors and asks for the strongest predictor, look for previous successful VBAC. Previous successful VBAC equals best predictor of future VBAC success. Okay, question number 3. What is the approximate risk of uterine rupture during planned VBAC? 1 in 50, 1 in 100, 1 in 200, or 0.5% or 1 in 1,000? So the answer is 1 in 200, 0.5%. This is another must remember figure for your exam. So far, we have two important numbers. VBAC success is around 72 to 75%, and uterine rupture is 1 in 200, 0.5%. But remember, this is the approximate overall risk during planned VBAC. The risk is not identical in every patient. It can increase particularly when labor is induced or augmented, which is why counseling and careful intrapartum monitoring are so important. And although uterine rupture is uncommon, it matters because the consequences for both mother and baby can be serious. So whenever you see the risk of uterine rupture in planned VBAC, think 1 in 200.5%. Okay, question number 4. A woman is now in labor with a planned VBAC. During planned VBAC, which fetal monitoring is recommended? Option A, intermittent auscultation, or Doppler every 30 minutes, or CTG only in second stage, or continuous electronic fetal monitoring. Now, the correct answer is obviously D. Continuous electronic fetal monitoring or continuous CTG. And here I want you to understand the reason rather than simply memorizing the answer. During VBAC, one of your major concern is uterine rupture. And what will be the first clue? Any answer? Very often, it is a fetal heart rate abnormality. In fact, and abnormal CTG is the most consistent finding associated with uterine rupture. That is why intermittent auscultation is not enough in a woman undergoing planned VBAC. Am I clear so far? Once she is in established labor, she should have continuous electronic fetal monitoring throughout labor. And remember, VBAC should be conducted in an appropriately staffed and equipped delivery setting where immediate cesarean delivery and advanced neonatal resuscitation can perform if required. Think of continuous CTG as a safety net of VBAC labor. Previous CAR and labor, continuous fetal monitoring. Okay, now let's make things a little more challenging. Which finding is the most consistent with uterine rupture? Option A, vaginal bleeding. Option B, scar tenderness. Option C, maternal tachycardia or an abnormal CTG. And the correct answer is, yes, please, abnormal CTG. Option D. This connects directly with our previous question. In uterine rupture, you may see abdominal or scar pain, vaginal bleeding, maternal tachycardia, cessation of previously effective uterine contractions, or even loss of station of the presenting part. But the most consistent finding is an abnormal fetal heart rate pattern on CTG. It's abnormal fetal heart rate. And this is exactly why continuous CTG is so important during planned VBAC. So in an examination scenario, if a woman with a previous cesarean scar suddenly develops significant fetal heart rate abnormality during labor, uterine rupture must be considered immediately. Don't wait for the classical picture of severe pain, bleeding, and maternal collapse. So in VBAC labor, abnormal CTG is a red flag for uterine rupture. Am I clear so far? Recognize early and act quickly. Okay. Which induction method has the lowest risk of scar rupture? Misoprostol or dinoprostol gel or Foley catheter mechanical method or high dose oxytocin? The best answer is yes, please. Foley's catheter mechanical method. Now understand the principle behind this question. See, the mechanical methods of Foley's catheter amniotomy. If an induction is required in a woman with a previous cesarean scar, mechanical methods are generally associated with a lower risk of scar rupture than prostaglandin method. So if the cervix is unfavorable and these are your options, a Foley or balloon catheter is the best answer. And here is an important exam distinction. Induction itself is not an absolute contraindication to VBAC, but it requires proper counseling because both induction and augmentation are associated with higher risk of uterine rupture compared with spontaneous labor. And also simply don't memorize that all prostaglandins are absolutely contraindicated in every VBAC. Recommendation differ according to the agent and guideline and local protocols should be followed. However, misoprostol should not be used for term cervical ripening or induction in a woman with a previous cesarean scar. Remember this thing. When the examiner asks for the lowest risk cervical ripening option in VBAC, think mechanical method like balloon catheter. Okay. Now, question 7 follows naturally from this. Induction of labor during VBAC increases the risk of uterine rupture by approximately how much? Option A, no increase. Option B, 1.5 times. Option C, 2 to 3 times. And option D, 5 times. The correct answer is approximately 2 to 3 times. This is another important counseling figure. Compared with spontaneous VBAC labor, induced or augmented labor carries approximately 2 to 3 times higher risk of uterine rupture. Okay, and there's another figure with worth remembering. The risk of cesarean delivery is also increased by approximately how much? Yes, please. 1.5 fold. Very good. So don't mix up these numbers. Uterine rupture around 2 to 3 times and cesarean delivery around 1.5 times higher. Does this mean induction is prohibited in VBAC? No. It means the decision should be individualized. The woman should be counseled about the additional risk. The indication for induction should be clear. The safest appropriate method should be selected and labor should be monitored carefully. Induction is not equal to contraindication, but induction is equal to increased risk. Okay. High dose oxytocin, more than 20 milliunits per minute during VBAC augmentation is associated with what? A, no increased risk. B, 2-fold increased risk. C, approximately 4-fold increased rupture risk. And D, 10-fold increased rupture risk. The best answer is approximately a 4-fold increase in the risk of uterine rupture. Now, oxytocin is not absolutely contraindicated in a woman undergoing VBAC, but it must be used cautiously. Evidence suggests that higher doses of oxytocin, particularly doses exceeding 20 milliunits per minute, are associated with a substantially increased risk of uterine rupture. So the principle is very simple. Previous uterine scar and excessive uterine stimulation is dangerous. If oxytocin is required, use it cautiously, titrate appropriately, monitor uterine activity. Oxytocin indefinitely in a scarred uterus, just don't keep escalating it. Always reassess the clinical situation. In VBAC, oxytocin can be used, but high doses deserve caution. So for the question, remember, more than 20 milliunits per minute, approximately four-fold high rupture risk. So now we know who succeeds, how much rupture risk is, and how to monitor labor and what happens when we induce or augment the labor. Question number 9, if a woman chooses an elective repeat cesarean section, when it should be scheduled? 37 weeks, 38 weeks, 38 plus 6 weeks, 39 weeks. The correct answer is yes, 39 weeks, 39 plus 0. And the reason is mainly, anyone? Neonatal respiratory morbidity. In the absence of another maternal or fetal indication for earlier delivery, elective cesarean birth should generally be planned at or after 39 weeks. Why not routinely at 37 or 38 weeks? Because elective repeat cesarean section before 39 weeks is associated with a higher risk of neonatal respiratory problems, including transient tachypnea and respiratory distress, and consequently a greater chance of neonatal unit admission. So we are trying to find a balance, not unnecessarily early because of neonatal respiratory risk, while having a clear plan if spontaneous labor starts before the scheduled date. So if you are talking about uncomplicated elective repeat cesarean section, think at 39 weeks. But remember the words in the absence of another indication. If there is maternal or fetal reason for early delivery, that changes your timing. Okay. Question number 10. When should prophylactic antibiotics for elective repeat cesarean section should be administered? After cord clamping, after skin incision, during skin closure, and before skin incision. The correct answer is D, before skin incision. This is an important change from the older practice where antibiotics were sometimes delayed until after cord clamping. Current practice is to administer prophylactic antibiotics within 60 minutes before skin incision so that adequate antibiotic concentrations are already present in maternal tissues when the incision is made, commonly within 60 minutes, and this reduces post-operative infectious morbidity, including endometritis and surgical site infection. So for cesarean section, don't wait for cord clamping. Antibiotic prophylaxis is given before cesarean section. Simple question, easy mark. Don't lose it. Okay. Now, question 11, this is a nice examiner trap. Which statement regarding epidural analgesia in VBAC is correct? Is it contraindicated, or does it directly increase the risk of rupture? Or should it be avoided in all women? Or is it safe but an increasing analgesic requirement may suggest uterine rupture? The correct answer is D. Epidural analgesia is not contraindicated in planned VBAC. As I told you, a woman attempting VBAC can absolutely have an epidural for labral analgesia. And importantly, epidural analgesia itself does not increase the risk of uterine rupture. Please make it clear this thing. Sometimes students worry that an epidural will completely mask the pain of rupture. It's not like that. But remember what we discussed earlier. Pain is not our most reliable warnings in any way. Abnormal fetal heart rate or CTG is the most consistent finding. However, there's a subtle clinical pearl here. If a woman has a functioning epidural and suddenly develops increasing pain or an increasing requirement for analgesia, don't just keep topping up the epidural without thinking. In the appropriate clinical context, this should raise suspicion of uterine rupture and prompt reassessment alongside the CTG, maternal observation, and progress of labor. So, epidural in labor is safe, okay, and unexpected increasing analgesic requirement. Reassess and think rupture. Okay. Question number 12. A woman has 2 previous lower segment cesarean section. According to RCOG, what you should tell her, VBAC is absolutely contraindicated, or elective repeat cesarean section is mandatory, or VBAC will be offered following senior obstetric counseling, or should labor only occur at home? The correct answer is yes, C. The VBAC will be offered after senior obstetric counseling. 1 previous cesarean section VBAC and 2 previous cesarean, automatically cesarean. This is very important because students often make this mistake of thinking that 1 cesarean VBAC, 2 cesarean, automatically cesarean. This is not necessarily correct. Women with 2 or more previous cesarean lower Previous lower segment cesarean deliveries may be offered VBAC after appropriate counseling by a senior obstetrician, but this is not a casual decision. It should be led in a consultant-led unit. You need to consider her previous obstetric history, previous vaginal birth, indication for previous cesarean, type of uterine incision, other pregnancy-related risk factor, her preference, and importantly, the resources available in your unit. If she proceeds with VBAC, labor should be taken place in a suitably equipped hospital with continuous intrapartum monitoring and immediate access to emergency cesarean delivery. So remember, 2 previous LSCs does not automatically equal an absolute contraindication to VBAC. Think individualized assessment and senior counseling and appropriate hospital resources, not an automatic no. Am I clear so far? So the next question. Which woman has a highest chance of successful VBAC? Option A, BMI 36, induced labor. Option B, previous C-section for dystocia. C, previous vaginal birth and spontaneous labor. And D, estimated fetal weight 4.5 kg. I think it's very easy peasy. Previous vaginal birth with spontaneous labor. And actually this question combines 2 favorable predictors in one option. We already know that a previous vaginal birth, particularly a previous successful VBAC, is the strongest predictor of success. Add spontaneous onset of labor to that, and the likelihood becomes even more favorable. Now look at the distractions. High BMI plus induction, absolute no, both reduce the likelihood of success. Previous C-section for dystocia, that is a potentially recurrent indication and is associated with lower success in a non-recurrent indication such as breech presentation. And suspected macrosomia also reduces the probability of successful VBAC. When comparing candidates for VBAC, look for the woman with the most favorable combination of factors, not just one positive factor. Previous vaginal birth plus spontaneous labor, excellent VBAC candidate. Okay, now question 14. Suspected macrosomia more than 4 kg is associated with A, higher VBAC success, B, lower rupture risk, C, lower VBAC success and higher uterine rupture risk, and D, absolute contraindication in VBAC. The correct answer is C, lower VBAC success and a high risk of uterine rupture. Now be careful with the wording. Macrosomia is associated with lower chances of VBAC success, and available data also suggests increased risk during labor, particularly in a woman without a previous vaginal birth. But does suspected macrosomia automatically mean VBAC is absolutely contraindicated? No, that is a trap. Estimated fetal weight itself is also imperfect. So this should be a part of an individualized counseling discussion rather than an automatic decision for repeat cesarean. And remember, macrosomia brings other obstetric concerns as well, including shoulder dystocia. So macrosomia makes VBAC less favorable, not automatically forbidden. Always distinguish a risk factor from an absolute contraindication. Now an interesting one. Which statement regarding preterm VBAC is true? Is it contraindicated or lower success than term, higher rupture risk than term, and similar success with lower uterine rupture risk? The best answer is D. Women who present preterm with a previous lower segment cesarean scar may still be candidate for VBAC provided there is no other contraindication to vaginal birth. The important exam point is that reported VBAC success rate are broadly comparable with term VBAC, while the risk of uterine rupture appears lower in preterm VBAC than a term. So don't see the word preterm and automatically choose cesarean. The indication of preterm delivery, fetal presentation, maternal fetal condition, previous scar, and overall obstetric situation still determine the mode of birth. So preterm does not equal contraindication to VBAC. Think appropriate selection first. Okay. Now, question 16, a woman considering VBAC is more than 40 years or older. Is that an absolute contraindication for elective repeat cesarean? Is it an absolute indication for elective repeat cesarean or contraindication to VBAC, or requires individualized counseling, or a reason for routine induction 37 weeks? See, the correct answer is C. Individualized counseling. This is another example of a risk factor versus contraindication question. Increasing maternal age can be associated with a lower probability of successful VBAC and with other pregnancy-related risks, but maternal age of 40 years or more by itself does not automatically rule out VBAC. So don't make management decisions from one isolated demographic factor. Look at the complete clinical picture. Previous obstetric history, indication for the previous cesarean, previous vaginal delivery, current pregnancy, maternal health, fetal factor, and the woman's own preferences. Age modifies counseling. It does not automatically dictate the mode of birth. Okay. So another question. Now let's combine. Is my screen visible to you all? Okay, yes, it is. So now let's combine several factors. Which women require the greatest caution when considering VBAC? Singleton, Singleton cephalic pregnancy, previous successful VBAC, post-date pregnancy with suspected macrosomia or BMI of 34. The best answer is C, post-date pregnancy with suspected macrosomia. Why? Because other options are either favorable or neutral. A singleton cephalic pregnancy is a usual favorable setting for VBAC. A previous successful VBAC strongly predicts another successful vaginal birth. A BMI 24 is not a concerning factor, but with the post-date pregnancy, with suspected macrosomia, we are stacking less favorable factors together. There will be lower likelihood of spontaneous successful VBAC or an increased risk of likelihood of needed induction and additional concerns related to a larger baby. But again, and this is important, greatest caution does not mean absolute contraindication. It means careful assessment, counseling, and individualized planning. In single best answer question, watch for cluster of risk factors. One relative risk factor may be acceptable, several together can significantly change the clinical decision. Question number 18. More than 90% of uterine rupture occurs when A, before labor, B, during pregnancy 28 weeks, C, postpartum, or D, during labor. The correct answer is D, during labor. And this makes physiological sense because labor exposes the previous uterine scar to repeated contractions and increasing the mechanical stress. The vast majority of scar ruptures therefore occur before labor has begun. And now connect this back to our earlier question. If the danger period is labor, what do we need during labor? Close clinical surveillance and continuous CTG. And what is our most consistent warning sign? Again, yes, please, an abnormal CTG. See how these single best answers connect with each other. Uterine rupture is predominantly an intrapartum emergency. So VBAC should take place with rapid recognition and emergency delivery are possible. Okay. The greatest maternal morbidity occurs with A, successful VBAC, elective repeat cesarean, failed VBAC requiring emergency cesarean, and successful elective repeat cesarean section. The correct answer is C, failed VBAC requiring emergency cesarean. And this concept is extremely important when counseling the woman. A successful VBAC generally has the lowest maternal morbidity, but the outcome we particularly want to avoid is a trial of labor that fails and ends an emergency cesarean section because that carries the highest maternal morbidity than a successful VBAC and generally more morbidity than a planned repeat cesarean. This can include hemorrhage, infection, operative complication, and a longer recovery. So when counseling, don't simply say VBAC is safer, cesarean is safer. The outcome depends heavily on whether the planned VBAC is actually successful. So successful VBAC is most favorable maternal morbidity and failed VBAC requiring emergency cesarean is highest maternal morbidity. And this is exactly why patient selection matters so much. Okay, according to RCOG, which audit standard is considered high yield? Weekly ultrasound assessment of scar thickness or MRI before labor, continuous CT documentation and consultant involvement in induction, and daily cervical and assessment. C, the best answer is yes, please. C. And even without memorizing an audit document, you should be able to solve this question using clinical reasoning and ask yourself, which option can actually improve the safety of VBAC care? Routine MRI? No. Daily cervical length? No. Weekly scar thickness scanning? Again, not a routine method for deciding whether a woman can simply safely undergo VBAC. But appropriate continuous fetal monitoring, clear documentation, senior obstetric involvement, and high-risk decision such as induction and immediate access to emergency cesarean delivery are genuine safety principles. So sometimes in a single best answer, you don't need to memorize every sentence of a guideline. You need to recognize what represents good clinical governance and safe obstetric practice. Safe feedback is not just about choosing the right patient, it is right patient, right counseling, right setting, right monitoring, and the ability to act immediately if something goes wrong. And with that, we have completed our high yield VBAC and elective repeat cesarean section SBA challenge. And if you remember only one thing from today, remember that VBAC is not simply a yes or no decision. It is about selection, prediction of success, counseling, monitoring, and timely intervention. Go back through these questions once again without looking at the answer and see how many you can now solve using the concept rather than memorization, because this is exactly how I want you to prepare for exam, for your FCPS, MS, IMM, MRCOG exam, and keep learning, keep practicing. And yes, we did it. We have completed a VBAC discussion. So we are not stopping here. In our next labor module lecture, we are moving to another extremely important and very frequently tested topic, induction of labor. We will discuss when to induce, when not to induce, how to assess cervical readiness, which method to choose, monitoring complications, special situations, including previous cesarean birth, and most importantly, हम सिर्फ methods memorize नहीं करेंगे. We will learn how to choose the right method for the right woman at the right time. So revise your bishop score before coming to the next lecture, because I'm definitely going to make you use it. And see you in lecture 5, induction of labor. Allah Hafiz in OBG with Sadia Idrees.